Hello, everyone. My name is Trevor Hertig. I got chapter 24, which is pain, on the Merrick Manual of Health and Aging. Um, so let's talk about that. So, first, the question is, what is pain? And how do we describe pain? Pain is not an unavoidable consequence of aging. You don't have to have pain once you get old. It's just a myth that that's what they say. When pain interferes with the ability to carry out daily activities, older people become more dependent on others, which is why we have nursing homes and those sorts of situations. What causes pain? Well, a lot of things cause pain. You can't really narrow it down to a specific number of things. In an older population, it's really difficult to find out what's causing their pain because it's more than one possible cause. And sometimes you can't even find out what's causing them pain. There's a lot of different types of pain as well. There's acute pain, there's chronic pain, there's pains referred, nociceptive pain, neuropathic, and also psychogenic pain. So let's go through each of those and try to differentiate them from each other. First, acute pain. Well, acute pain is pain that develops suddenly and does not last very long. It's usually caused by an event that has a clear beginning and end, such as an accident or a surgery. With this type of pain, with acute pain, you're going to know where it came from. You're going to know specifically how to help them with that pain because you know the cause of the pain. However, chronic pain is pain that develops gradually and lasts a long time. It often has no clear beginning or end, especially when the cause is a chronic disease like arthritis or like diabetes mellitus. So if they have a comorbidity like arthritis or diabetes, necessarily they might be having pain in you for a long period of time, and you don't necessarily know how to fix it from there. Next, we have the other four types of pain, which is referred pain, nociceptive pain, neuropathic pain, and psychogenic pain. Referred pain is pain that's in one area, but it's like felt in another. It happens because messages from several areas of the body often travel along the same nerves, going to the spinal cord and the brain. We all know what referred pain is. Nociceptive pain is pain from an injury that stimulates pain receptors. Neuropathic pain is abnormal nerve activity. Where a nerve is injured, it causes pain to persist long past the time expected for healing of the injury. Psychogenic pain, it's pain attributed to a psychologic cause when no physical cause can be found, such as depression. Because depression can also be considered a type of pain, but it's more of like an emotional pain. So, what are symptoms and how do you diagnose it? Well, pain is described in many different ways. There's aching, there's throbbing, there's squeezing, there's burning, there's shootings, there's stabbings. Um, so it can be described in many, many different ways. We already know, depending on how it's described, it leads to a certain differential diagnosis that we can assume. Neither examinations nor tests can prove that a person is in pain, because pain is all subjective. You need to ask questions about the pain. You need to ask about the past and present medical problems that could contribute to the pain, current and prior drug use, including all pain relievers, and then ask them to rate the intensity of the pain on a scale, either like 1 to 10, and this can just be done on a visual analog scale. Some people do it from 0 to 10, or you can just do it from 1 to 10 as well. So what type of questions should you ask? Well, you need to ask, when and how did the pain start? Did it begin suddenly? Did it gradually come on? Was there a specific event that it seemed to trigger the pain, which would be an acute situation? What is the pain like? Is there a pattern? For example, is it steadily worsening? Is it always present? Does it come and go? Is it only after meals like GERD? Or does it like disrupt your sleep like it could cancer in a sense? How intense is the pain? Again, that's that scale from 1 to 10, the subjective pain scale. And then have them, where is the pain? Have them point to it. What makes the pain worse? What makes the pain better? It's just our palliative, provocative. And then how does it affect your ability to carry out daily activities? How does it affect your ADLs? How are sleep, appetite, and is it causing you bowel inconsistency, or is your bladder function affected? Does the pain affect your mood or your well-being? Is the pain accompanied with the feeling of depression? For the older population, it's very important to understand where their state of mind is because that'll help with their pain as well. So how do we obtain information? For an older person who has had a stroke, you may not be able to get those answers because of damage to parts to the brain that they can't control their speech. They could use sounds, blinking, or hand gestures in order to communicate. You can ask them to show pictures of faces, point on a scale from a happy face to a sad face, and they point in the middle, it would be a scale of a 6. May have to rely on observations from caregivers if the patient has dementia, ask about a change of behavior or a decrease in appetite. If you have other sources to use that can help you help your patient, then you'll need to use those. Ask other physicians, ask caregivers, ask the family if they're taking care of them. Physical examinations such as facial expressions, frowning, grimacing, light wrinkling of the forehead, and rapid blinking of the eye, closing, it may suggest pain. Look at their facial expressions, their body language, that can all determine if someone is in pain or not. Also, pale skin, sweating, trigger points, joints and swelling and inflammation may also produce pain. So with our palpatory skills, if you're finding a trigger point and it hurts them, of course that's producing pain. That's what it's saying. Treatment options. So often pain goes away by itself. When pain worsens or persists, people usually seek relief, which means they come to see us or other primary care physicians. Pain is most often treated with drugs, but there are many effective non-drug treatments. Drugs combined with non-drug treatment can result in better pain control than either method used alone. So the book explained that you can go for non-drug treatments, which is my next slide, which is acupuncture, chiropractic, but also they're so far into that chronic cycle that they might need a supplementation of pain relievers in order to control it fully. So what are some non-drug treatments? So non-drug treatments would be like stretching, massaging, applying ice, heating pads, TENS units, acupuncture, cognitive therapy, psychologic therapy, chiropractic, anything that's just not involving medication, you can use. For drug therapy, so older people are more likely than younger people to experience side effects. We already know that from previous chapters. The process, since we won't be administering drugs, we don't have to know about the start low and go slow, but it's like start out with a smaller percentage of that drug and then slowly build up so you know what the side effects are and you can treat them if possible. The approach usually enables older people to safely obtain relief from pain, and then it eliminates the factor of overdosing to a sense. Chronic pain is best treated with long-acting or sustained release drugs that provide steady relief over many hours, and then relying slowly on slow-acting drugs may result in peaks of relief alternating with valleys when the pain is poorly controlled, which is why it's good to have their lasting ones. So you mix them together and have a slow one that gets them to the pain relief that they need, and then it lasts for a while with the chronic pain relief. So this is my longest slide. So we can divide into 3 main categories. We have non-opiates, which are your NSAIDs, which are ibuprofen, aspirin, COX-2 inhibitors. They reduce inflammation and also pain relief. And then acetaminophen is also in here, but acetaminophen is for pain relief only. Opioids. Opioids are the most powerful analgesics. They're used in situations of acute pain after surgery and chronic pain from cancer. They are highly addictive, and people develop tolerance and withdrawals from them. Side effects include constipation, confusion, drowsiness, bladder dysfunction, nausea, loss of appetite. Taking too much can cause slow breathing, coma, and even death. And then naloxone is given if that happens. And then adjuncts, they're antidepressants, local anesthesias, things like that. They can help relieve pain in who do not have depression. And then anticonvulsants can be used as well to relieve pain caused by abnormal nerve activity. And these are the opiates that are seen most in the world. There's methadone, morphine, oxycodone, oxymorphine, all the drugs that we hear that people are overdosing on.